Mm-hmm. Manifestations.
Yeah.
Oh yeah, that you added. Did you add that?
Yeah, I put that in. Yeah.
Okay.
Wrote the whole thing.
Oh, good job. Let me take a picture.
Resulting in thrombus formation with the route embolization. What's the difference between the two? Thrombus versus not with or without the embolite. Say what? One move, yeah. But thrombus is just going to be what? An obstruction is going to be there, an occlusion in there. If it breaks free,
It's an infarct.
then you can get what?
Infarction.
Infarct or ischemia. And we talked about collateral blood flow, right? I think that's last time we talked
Yeah.
about. All right. Do we go this one? Abrupt onset?
No, we haven't started
Okay.
it.
My 20-year battery died, so I don't know my point. So, manifestation in AMI is going to be acute myocardial what? Infarction, right? So abrupt onset, severe crushing pain, usually substernum, radiating to the left arm, neck, and jaw. I want you to think about this one in a second, right? Just hold on for this, okay? Gastrointestinal complaints, nausea, and vomiting. Complaints of fatigue and weakness, tachycardia, anxiety, restlessness, feelings of impending doom. And those are all manifestations of heart attack. That feeling of impending doom is kind of weird when it comes off. Pale, cool, and moistened skin. What particular patient type are they talking about here?
Adult? Male?
Adults, but
Male.
Male, right?
Because
What's the difference?
women have different symptoms.
Women can have manifest different signs and symptoms from this. They don't always have this crushing pain, usually substernal. A lot of times they don't have the pain radiating down their arm. So they're finding out now that women have different symptoms than men do cardiac arrest.
Do you know why? I've always wondered why.
I don't know if they know why, because I mean, they just always assumed it was the same. I think a lot of women may have had heart attacks back in the past and they thought it was something else.
So then what are the symptoms for women?
Back
I'm gonna have to
pain.
look those up actually.
It's
I'll
like
do
back
this
pain's
morning or
one.
after.
Back pain's one.
I think it's back pain.
And then-
Some of these other ones they get, like they get this and they get sort of the fatigue and they get this too, I know. But the one they really don't have is that crushing chest pain, I think, and they don't have the radiating. So it is back pain. I'll look them up. All right. Cause of unstable angina are arthrosclerotic
Plaque disruption.
plaque. What's a plaque?
Plaque.
Plaque disruption, which means what?
It's broken free.
It's going to break off, right? Platelet aggregation, which is going to precipitate what?
Blockage.
Blockage of plaque formation, right? You're going to get platelet aggregation. And then what's secondary hemostasis? What does hemo mean?
Blood.
What is stasis? Right, stopping, right? So hemostasis is going to be what? Preventing loss of blood. So it's going to be clotting, right? And the ultimate result of all three of these is going to be what? Not necessarily.
No.
Could lead to heart attack, but what?
Blockage.
Huh?
It's going to be like a blockage. Pain.
It's going to be an occlusion of the vessel at some point, right? You can start occluding that vessel depending on the degree.
And occlusion means blockage?
Yeah,
Okay.
occlusion, that's what it is, yeah. So when you guys get in, they'll talk about patients, they'll do an angiogram on them or something, and they'll have a percent occlusion of
Yeah.
the left coronary artery. So it's going to be an 80% occluded artery. That
Yeah.
80% of that vessel is what?
Blocked.
By that occlusion. All right, so locate, they're talking about the extent of the infarct. Location and the extent of the
Occlusion.
The amount of heart tissue supplied by the vessel, so I want to go through these one by one and talk about it. Duration of the occlusion, metabolic needs of the affected tissue, extent of collateral circulation, heart rate, blood pressure, and cardiac rhythm. How do all these come into play to determine the extent of what? The infarct.
So what are you asking? How do they?
How? Tell me how. That's what it says. It's telling you these do, right?
Mm-hmm.
Now tell me how.
Well, the location would be what pathway is blocking.
Okay, so location is going to be what? If
Is
you
it
have,
blocking, like the aorta or
the aorta is going to be outside, so this is going to be on the heart. So you wouldn't have it so much on the aorta, not an infarct, right?
No. It'll be like on the
So what do they mean? I would draw a heart, but everybody always makes fun of my heart.
Oh, that's not bad.
Not bad.
That's not too bad.
So it would just be like the location would be where the oxygen.
Well, it would be on the
being
outside.
affected. So what area is getting blood supply to?
Okay, so what, give me an example where it would be less crucial.
And where ones sending
Beef.
tissues that aren't as important.
Which tissues?
Heart organs maybe.
But no, we're just talking about the heart right now, right?
Okay.
So we're talking about location and extent of the occlusion. So you got all this cardiac circulation that's come down, right?
Right. Well, what you don't want is it to be on the beginning of a branch, right? Like
Okay. But right now we're talking about
location.
Okay, they got the duration,
Uh-huh.
and the location, the extent. So yeah, if it's on a major branch, that could be a big problem because if it's up here,
Yeah.
what's gonna happen?
It's gonna stop everything to that lobe.
Could be everything down here, right?
Yeah.
But even if it's just say down here, would that be worse than say maybe one that was going up this direction?
No. Yeah. Because it goes like that.
Well, why?
Because it.
Okay, this flow is going up to the top of the heart. This is going down.
The
That's
one is toward the circulatory system.
Okay.
And systemic.
Okay, well let's put it over here.
So your
Over
question
here.
is why one is worse than the other, or you're telling us?
So we're talking about location. So we're talking about that. If you got a major vessel going in, you get massive damage. That's bad, right? So
Uh-huh.
like that. But now let's say is it going to be worse? You have an occlusion down here. So now all this is going to, or up here, and this is going to hurt.
Isn't the bottom ones worse? The ventricles worse because they do the most
What do y'all think?
work.
Well, the left is the major pump. So
What do you all think that you know about it? What do you think? Is it going to be worse to have a
I think
myocardial
I think
infarction
ventricle.
over the atrial tissue is around the atrium or around the
Ventricle. I think ventricle.
ventricle?
Probably
It's
the
gonna
ventricle.
work.
I would say ventricle.
I would say ventricle.
Because it's
Yeah.
more important.
Because that's the main pumping part of the heart, right? The
Right.
atrium just does what?
Passes through.
Passes, blood just goes through, and you can have an AFib, and you're not going to have a needle problem. Now, if you had a massive one up here, though, what might you also possibly damage, though? There could be
The
problems.
valves.
Not the valve so much. The conductivity pathway. If you got
Oh,
too
the
much dead tissue,
nodes.
then you might have problems because you can damage what? Conduction of the electrical impulses down there too. But hopefully it should go around everything else. But you have a massive ischemic event over the left ventricle. That's what they call a widowmaker.
Yeah.
Because what happens?
You can't even fix
pump
it
out.
because if
Yeah,
it's something
well.
happens to the atrium ones, they can do pacemaker to fix the nodes and stuff, right? They can
Yeah.
work with you.
You can put a pacemaker on there if you lost conductivity.
Yeah.
Even if you lose some conductivity here, is it necessarily going to be deadly?
No,
Why not? Ooh, back to A and B too.
damn.
Why not?
There's other pathways.
Okay, the pathway goes to SA node, AV node, bundle branches, Purkinje fibers.
Uh-huh.
So if I got some damage here and I was having trouble,
Will your brain take over? Maybe.
no, brain.
Mm,
Why? Why
mm.
would not
Usually
be?
wouldn't stop it though, it would still be,
So let's say you have massive
it's just
damage
kind of
here.
like causing.
So you lost that conductivity pathway, right? So
Yeah.
that pathway from the AV node, SA node to the AV node is now damaged from dead tissue.
Damn.
You've lost that pathway.
Can you have a pacemaker?
Like
do
there's
that?
a-
We're not putting a pacemaker yet.
So-
you got to get, hold on.
Your question is-
Hold on.
Your question is why you don't die right away,
Yeah,
right?
so let's close it over here. So that SA node, right?
Got it. Yeah.
AV node, it's gonna go. Gonna hit here.
Uh-huh.
Go down there,
Yeah.
right?
Got it. Yeah.
I got this heart backwards, just so you know. So why, if I have a massive blockage here, is it not gonna drop you like this down?
Yeah. I don't know.
Because it still gets the signal there to where it needs to be.
Okay, but I blocked
How?
a lot of the signal because of dead cardiac tissue.
It's just not as fast.
Not as bad, but what, but so if I block the tissue, that signal pathway from the SA node to the AV node, why would it not be at least acutely fatal?
Yeah. I don't know.
It still gets to the Doesn't it still get there?
How?
But all this tissue dead.
How could it still like pass?
So you got all that river goes around the outside of the atrium, right? Causes that contraction, you get that pathway. If you lose that, how come it would not be
It still
fatal?
keeps pumping.
Why? How would it still be fucking?
The,
You're gonna kill yourself when you figure this out.
I mean, because the left ventricle gets the signal.
Does gravity have anything to do with it?
Left brain, they get the same signal. That signal fires, that signal goes down both the atriums, right? Boom, around the outside of the walls, the conducting cells around the outside of the atrium, right?
It doesn't.
Then it hits the AV node, then it goes zoop down the
Yeah, and then it pushes.
septum, and then comes back around. No, this is in milliseconds, right?
Yeah.
Okay. So if you get a bunch of damage out here, let's say it's above that left ventricle, why would it probably not be immediately fatal?
Because
No, go ahead.
maybe my
I'm just saying the signal still goes.
It can't go if it's dead, though.
It's not stopped.
Well, what about the
Even though it might slow down.
Why wouldn't it be stopped though? You just lost that conductivity from the SA node, that's your pacemaker cells.
But the other one picks up the pace.
That's what I was looking for right there. If the SA node gets damaged, the AV node can take over as the pacemaker, but what happens?
What's the strain?
That little second.
You don't worry about that, it just slows down. It's about 50 to 60 beats per minute, right?
Oh.
As opposed to that
That's right.
75 and above.
Got it. So it still works, but slower.
Mm-hmm.
Yeah,
But just be
it's
slower.
Still works, you still be slower, so it definitely wouldn't be immediately fatal per se.
So on an EKG, how would that present itself?
With this block?
Yeah.
Oh.
Would it be all crazy, or would it be
How
all?
would it present itself? Good question.
Would it look all like?
It wouldn't be the P wave.
It would go slower.
It's gonna be a first degree heart block, right? Because you lost that conductivity, you're gonna lose that P wave.
Okay.
Good, very good. That's all we're talking about. This is gonna determine the extent of that infarct. How damaging is it? The location and the extent of the occlusion. If it's at 50% occlusion, you're still gonna get blood supply in there, right? The amount of heart tissue supplied by that vessel, that all ties back into this, right?
Mm-hmm.
Depends on how much blood supply that vessel. If you've got more blood supply going to it, if it happens to be somewhere where you only have one vessel going to it, that could be bad. That tissue's probably gonna die. Okay, duration of the occlusion.
How long?
Okay. Metabolic needs of the affected tissue. If it's a highly contractile cardiac muscle that needs a lot of what? Fuel and oxygen, it's going to be more damaging than it's something maybe in the sternum in there that really doesn't do that much, right?
That's true.
Ira. Extent of the collateral circulation, we talked about that. If you have a good collateral blood supply, it may not do anything.
Yeah.
And the heart rate, blood pressure, and cardiac rhythm. All right. So, transmural infarcts involve the full thickness of the ventricular wall and occur when this obstruction occur when there is an obstruction of a single artery. Some endocardial infarctions involve the inner 1/3 of 1/2 of the ventricular wall and occur more frequently in the presence of severely narrowed but still what? Patent arterial. Somebody's just going to put through real quick. So, populations affected by ischemic myocardial ischemia. Ischemia. Persons who are asymptomatic without other evidence of CAD. Oh, man, I can't even talk this way. And what does that mean?
That they can't feel it.
So what's CAD again?
Oxygen, lack of oxygen, right? No?
Nope. CAD is what?
Oh, CAD. I thought you said
Coronary
ischemia.
artery disease.
I
Right?
thought you said ischemia.
So populations affected by silent myocardial ischemia, people who are asymptomatic without other evidence of CAD. You've got a 50% occlusion. My father, my poor family is going along. My father was going along. I know I should have been doing it. Don't tell me that. I had somebody tell me that one time.
How old are you?
I was old enough to be going along.
Okay.
And he felt kind of weak and dizzy. Went inside, went to see his friend's cardiologist. They had a stress test. He had a 90% occlusion in one of his major arteries.
90?
But because he had really good collateral blood flow, it actually said it saved his life. Oh, that's good. I would have really been in trouble. So, but he had a pretty big occlusion in there, right? So did he have cardiovascular disease?
Yes.
Coronary artery disease, I'm sorry. Did he?
Yes,
Did
he
have
did.
an occlusion of one of his major
Yes.
coronary arteries?
Yes.
So he would have fallen into this category, right?
Right.
I'm probably in this category.
No.
Persons who have had a myocardial infarct can continue to have episodes of silent ischemia, so you have that first big one, and then after that you just don't realize it. And persons with angina who also have episodes of silent ischemia. So that's going to be that one where you get those temporary occlusions, you get that pain, you lose that. What is ischemia again?
Loss of blood flow.
Blood flow, so you're going to lose what?
Oxygen.
And oxygen. So, but it can last for a little while, right? You just start stressing some of those cells. That's what I'm doing. We'll get to the end of the time and go over a couple of tissues that do. This is crazy. What's that?
They're gonna close press.
All right. Medical management of
Yeah,
colic infarct. I took all the embryological stuff out of here, guys. I'm looking at other stuff now.
I noticed that, oh, I'll tell you after class. Okay, go ahead.
My trash can's going to be in Las Cruces one.
You always have them on trash days.
It does. I hope they at least picked it up, otherwise it's, yeah. All right, sorry. Thrombolytic therapy, what does that mean? What is thrombo?
The clot.
And what is lytic?
All over.
So it's just like destroying?
Yeah, lysis. Lytic to break up
Oh.
apart. Right? So thrombolytic therapy is going to, what's the generic
Clot
term for those
destroying?
drugs? Clot busting drugs, they call a lot of them. All right. Revascularization interventions. Ooh, I love the terminology they come up with this. All right. What is a coronary artery bypass grafting?
That way you get it from somewhere else and put it,
We'll get what more.
like get the
You're an artery from a different part of the body.
from your vein and from your neck. And then kind of make another pathway
Like a bridge.
to do it.
Okay, so what it is, a bypass, your bypass. So you guys are right. So coronary artery bypass, that's when you guys can come in and do a bypass. We're going to do a bypass on you. They go down, they usually like to take some of the big veins out of the leg. They're trying to switch to arteries now, sometimes they seem to, they go back and forth.
I would think, yeah.
Well, but it's a short little area, and you really want to just keep blood moving. You just want to make the blood move, right? You're not worried about blood pressure or anything at this point, right? Really, it's coming right out of the heart, right off the atrium, right? So they take big grafts out of your legs, they take it up, and if you've got an occlusion right here, what are they going to do?
Make another pathway.
Yeah.
Make a bridge or.
Oh.
Basically that simple. They just bypass, it's kind of like they're doing down here, right? They just bypass the occlusion. Yeah, a lot of times
But it's not risk for like blood clot.
can be. They usually, yeah, it could be. It could move. Usually, a lot of times, though, these things are like, start doing it.
Oh, I was gonna ask, aren't they afraid of it embolizing? Like, but
No,
no.
because a lot of these are probably embolized, they're already wedged in. They've already gone and moved into it, gotten to the point
Where
it's
they're
like
not
falling
going
apart.
nowhere. Okay.
Now, what is this one? Percutaneous coronary intervention, PCI.
That's when they did the stent.
Catheter for the stent, right?
Yeah.
So what's an angioplasty? What's an angiogram?
Isn't it a angiogram?
That's when they inject you with a dye into your
Yeah.
coronary artery system, and they follow the dye as it moves through. And if the dye is moving through here, and this lights, so we'll get rid of this.
And it stops.
And this lights up, and then it's dark here. What is that telling you?
It's not passing.
You're in trouble, right? Okay. So angiogram. So what is the angioplasty? And then the stent. Because you have to crack open the chest to do this.
No.
No, you said you go through what usually the femoral artery. Catheterized, yeah. A lot of times they want to do femoral. So what is it?
You place it through the narrow, already through the narrow arteries, right? You try to remove the plaque that's already including it.
So how does it tell me exactly the function?
It's like a balloon, right?
Good, it's called balloon angioplasty in this case. So you have this little thing that goes in there, it's got the stent wrapped around it, and the stent is like a little cage,
Yeah.
okay? And it goes in there, and they blow up the balloon. And if you're down here and you don't have this, so you've got an occlusion like this, right? They're gonna put it in here, and they're gonna blow up that balloon, and they're gonna push the clot, squish the clot back, right?
Yeah.
And as they do that, that little stent, you ever see those Chinese finger things that they stretch?
Yeah.
The opposite. As it fills up, it pushes it and opens up, and the stent should open up.
To keep it open, right?
Yeah.
Like a cage.
And they leave it in there?
Yeah.
Yeah. Leave it in there. And a lot of times they'll actually coat these now, because what could be a potential problem with having a metal stent in your artery?
Rust.
Tissue wraps around it, grows around it.
Good tissue, you get an immune response, and you get plaque buildup formation on there. So a lot of times what they're doing now is they're actually putting some clot inhibitory chemicals or drugs actually on the stents now. They're trying to do that. If it's too bad, they'll just keep you anticoagulated. Okay, good. This one is what? Arthroectomy was what?
But I've always wondered about the stent. Why? So I guess, like you said, they do put them on an anticoagulant. But if they didn't, wouldn't another clot just get caught in that stent? I've always wondered about that.
Well, they're just hoping you don't have any more clots.
Oh, okay.
Yeah. And it could. And that's the problem. Have you seen those ads?
Yes.
The little
Mesh
the
implants?
little cages, they kind of look like this.
Yeah.
Yeah.
So they put those in there. They're filters actually, and the idea is they wedge those in there, and then if another clot has come through here in a bigger vessel, then these will catch the clot before they get further.
And then, of course, you keep getting checked on to make sure on those stents.
If you watch all the lawyer shows, advertisements, what's the problem with these little filters? They're breaking. So now you got a little piece of this filter flowing through your vasculature.
Oh my God.
And one company, if the lawyers are correct, which I never believe lawyers, they're saying that they actually developed a procedure and an instrument to go retrieve those broken pieces, and they did not get FDA approval for that. And if that's the case, that company's in big trouble. Yeah.
How often should you get your stent checked
Mm-hmm.
to see if it's?
So I don't know. I've never had one. I would think pretty regularly, and probably at least yearly, I would guess. I don't know. Let me ask, I'm gonna ask the cardiologist on how to do it.
I asked because I take care of my godmother,
Uh-huh.
and she has a stent, and one of her other arteries is completely clogged, but they couldn't unclog it for her because it runs a lot of risk.
Mm-hmm.
And she's having a lot of trouble breathing and walking a very short distance.
Has she gone to the cardiologist lately?
I've told him and stuff, but he hasn't really done anything about it. And I wonder how often are you supposed to get?
I'll ask somebody. I'll ask the cardiologist.
She got a stress test, but
And the stress test was okay?
it was normal.
Was it a nuclear or was it the exercise one?
Nuclear.
Well, that's usually pretty
Yeah,
good
she can't
indicator.
get on
Oh, this way,
she can't get on the machine.
that's me like, I can't do that. That's usually indicative it's pretty good though. Well, I'll see if I can ask her about that.
She takes
Does she have any
Revlimid.
lungs? Does she have any other respiratory problems though?
No, she doesn't. She takes blood thinners. She has other complications, but
That's interesting because the nuclear stress test didn't show much. That's usually a pretty good indication that
yeah, I didn't show it at all. But she still complains that shortness.
that might be a good case study later on. We'll look into that. Remind me that that's on there. Okay. Then we'll look into that. All right. Now, what is one of the problems with angioplasty? Because in the past they didn't have these stents.
So what they do is just try to
With
push
the
blood through
They
and
would,
we.
yeah, they just try
so
to
would it grow back?
Yeah, sometimes it would go back down and come back
Yeah.
down again. So years ago they didn't have the stents. Okay, this right here is to clean out the plaque. What did I put here?
Roto-rooter.
That's actually what they call it.
So how do they clean it out with it, like a stent, but pull it back out?
Same thing like the angio.
It's got like a sharp blade, right?
Yeah, and some of them actually spin, and then they've got a vacuum attached to them, and they just rotor around your vessel. All right, and then cardio rehabilitation programs, cardiac rehabilitation programs. All right, non-pharmacological treatment for angina, smoking cessation in persons who smoke, obviously, reduction of stress. These are pretty common sense, really, right? Regular exercise program. This is a big one. And what is the? Let me go back to this one a minute. All right. Limiting dietary intake of cholesterol, saturated fats. How come I put this on here? Weight reduction if obesity is present. That definitely helps. This kind of goes back to this and this. Avoid some cold or other stressors that produce what?
Vasoconstriction.
Yeah. You don't want to constrict a vessel that's already potentially occluded, right? Because that causes what? bad stuff to happen, okay? But I want to go back to these two, right? What is the problem with this one?
Won't it
There's a lot of things
release
you guys need taken care of.
Which one?
regular exercise?
Most of them can't do it.
Yeah, and what happens when they first come out, they must have triple bypass surgery, angioplasty, whatever. What's the first thing the cardiologist has them do? Well, not the very first thing. I mean, I don't mean when after recovery, I mean in their life. They usually go to cardiac rehab, right? And you go to cardiac rehabilitation, which is going to be this part right here.
Okay.
Right? Problem is, what happens to a lot of patients?
They don't keep up with it.
They don't keep up with it. And that's a huge problem with that. Because they start off, they're like teenagers. They start off really doing well, and they, as long as they've been prescribed, they're going to the cardiac rehab center. A lot of them do really well, but compliance becomes a huge issue with it.
At the rehabilitation center, they make them do the exercise and the diet. What are you talking about? I don't.
Right here.
Okay.
So when you get out, if you were going, your cardiologist actually prescribe you
To go to that center.
Cardiac rehab.
Yeah.
And you'll go down to a cardiac. It's a gym.
Oh, it's a gym.
And they'll put you on stuff like that.
Oh,
right?
okay.
To get you everything go back up. And the funny thing about it is a lot of patients, they love it at first, right? Like, I really like this. I never exercised before, but then they just fall off. It's just a weird trend. How about this one right here?
Well, because their diet's already screwed up and their cholesterol's screwed up.
But isn't that already controversial? They're saying cholesterol doesn't come from food. We found out now.
The big issue now, if you talk to a lot of physicians, the amount of cholesterol you get from your food. And again, it's at 100%. Next week there may be another study that changes it. That most cholesterol is genetic. You just make too much of it, or you don't get rid of enough of it that you make. The idea now is your dietary intake of cholesterol is not as critical as they once thought. They used to think that was the main factor, right?
Yeah.
It was dietary cholesterol. Now it's not so much dietary cholesterol. But things change. Well, I was going to tell you guys, always keep up with this stuff. Because in the 70s, the egg was the most evil thing out there, right?
Right.
Now it's been a superfood. Well, I just saw a new article, another group has come out and said, oh no, it's back to being the devil again. So I want to look into that one because the cholesterol in it. I'm like, so just, the whole point is how much does this help? But ideally, is it going to hurt?
No.
Certainly not going to hurt, right? So. Aspirin, because these are going to be antiplatelet and anticoagulation therapy. Aspirin, how does aspirin work? The preferred antiplatelet agent for preventing platelet aggregation in persons with coronary artery disease.
It doesn't allow the platelets to stick together, right?
Stick together?
Not
To form?
the blood thinner.
The blood thinner, right? It prevents aggregation, so it inhibits synthesis of prostaglandin and thromboxane. I'm not going to go through the whole pathway, okay? But it inhibits clot formation. In fact, if you're going for major surgery, they want you to be off aspirin for how long?
$40?
At least
What?
a week. Some, yeah, it's got pretty long. It's anticoagulation effects are longer than you think.
Oh. Why is it over
What
the
is this one
counter?
right here? Cyclid and then Plavix. You all heard of Plavix?
Aren't those anticoagulants also?
They're anticoagulants, maybe used when aspirin is
Contraindicated.
contraindicated to use, right? It irreversibly inhibits the binding of ADP to its receptor on the platelets. So this is affecting just what? Just platelets. So no effect on prostaglandin synthesis, which can have downstream effects. Okay. These specifically target this receptor just on where? On platelets. So it's a target specific drug. Now they are starting to have some side effects on this. I've seen that they weren't anticipating. But anytime you're anticoagulated, what is one of the potential downsides?
You can bleed to death.
Too much bleeding.
But just walking down the road. You're gonna bleed to death?
If you cut yourself.
Well, even a bruise.
Or hit yourself.
That's one of them if you're really severely anticoagulated. What are some of the other problems if I'm not? That they come across? Do you still occasionally have bleeds inside your body?
Yes.
Yes. Especially your brain sometimes too, right?
Yeah.
So normally your clotting mechanisms are going to interdict those before they get too bad, right?
Right.
If you have your anticoagulated, this could cause what?
To bleed to
big
death.
issues.
Yeah.
You start having internal bleeding that you normally would be able to recover from on your own, that you can't recover from because you're anticoagulated.
So why did they put you on baby aspirin or Bayer?
Because the anticoagulation effect is much lower than the anti-inflammatory effect. The dosage is lower. And they want to try, so that's sort of that therapeutic threshold. So that, now that's another problem. Did we talk about that here? Or is that my other class?
I don't know. Go on. I'll tell you halfway through.
Okay. So what were the two mechanisms? Oh, we got a wild code going on out there. What were the two reasons to take aspirin in the past decade?
Pain. Pain
Prevent
management.
heart attacks, right?
Uh-huh.
And what was the other one they saw had?
Fever reducer?
No, for preventive therapy.
Oh, preventative?
Yeah, but no, we're talking about the general population.
Why then?
It seemed to decrease the amount of colon cancer, the risk of colon
What?
cancer. Because it's anti-inflammatory response.
Oh.
Okay. So now they've done study after study after study. And so why do they use a low dose versus a high dose?
Less risk.
Less risk. If you take high doses of NSAIDs for long periods of time, what are the potential downsides?
Liver.
Side effects.
Not so liver, but kidney's a huge one. The kidney, the NSAIDs are really hard on your kidneys. They can cause some liver, that's usually more acute, but kidneys is a big one. And
Stomach ulcers.
stomach ulceration is the other one. So that's why they put you on that low dose. Two things that come out of the latest studies, these big long studies of that. A, it does not seem to prevent a first heart attack.
It
So
doesn't?
you guys don't need to be taking it right now if you haven't had a heart attack.
Oh, it's that.
The benefits do not even get close to outweighing the side effects if you have not had a heart attack already. So that's one that's off. Secondly, if you are trying to do it for cancer, colon cancer, it only works if you're about 140 pounds or less.
Wow.
Which knocks me out by just a little bit. Why? How do you like that? Put my self-esteem down. So that knocks a lot of people out, right? So I went over that thing in APT one day or one of the other ones. So the point is now you can, now how could you get that anti-colon cancer effect if you weigh slightly more than 140 pounds? You up the dosage, right? But at that point, the benefit is outweighed by the risks at that point. So it's all cost benefit analysis. All for that. So platelet receptor antagonists target a single step in the aggregation process, and they block the receptor involved in the final common pathway for platelet adhesion, activation, and aggregation, and they treat acute coronary syndrome. These are better because these target specific single parts of a pathway. You get things like heparin and some of these other ones, warfarin and some of those, they tend to have more broad-ranging effects. That's the idea, is to try to target therapy, so you're just stopping platelet aggregation.
What would be an example? Because I thought warfarin was, but
warfarin or Coumadin stops a particular part of the pathway, but it's pretty high up, so everything downstream gets knocked down. Whereas these target just what? So you're targeting that targets part of the enzymatic cascade.
yeah.
This targets a particular receptor just on platelets.
What's like an example that I've probably heard of, like?
What drug?
Yeah.
Plavix is going to be. That's what Plavix is.
Plavix.
And what's the other one out there they talk about? Because if you look at them, they attack the ADP receptor on the platelets.
Well, Plavix is the more known one, right?
Yeah, but there's 3 or 4 out there now.
Oh, okay.
They always have athletes doing for some reason. I don't know what that has. Okay. Which type of angina is brought about by exercise or stress?
Stable.
Stable?
Yes.
Oh, I forgot to take the answer.
I didn't even look at the answer. I got that one right on my own.
Right, and you sit there watching TV and bad. You get enough of a blockage in there. So if you get a little bit short-term blockage of blood flow from unstable angina, is that going to cause an infarct necessarily?
No.
No, it depends on how long it's going to be, including what's going to happen. All right. Myocarditis is what?
Inflammation of the heart muscle.
But what part though? Not just the heart, the what?
nose.
If it's myo, it's going to be what?
In the
Muscle?
Muscle.
Yeah.
Good. without evidence of myocardial infarction.
Inflammation of the heart.
Primary cardiomyopathies are heart muscle disease of unknown origin. Still think they always do these things backwards. If I were doing this, I would have what I know first, make that primary, and what I don't know, but you guys, it's just the way I think. Secondary cardiomyopathies are going to be what? Conditions which involve cardiac abnormality results from another cardiovascular disease, myocardial infarction, what else?
Genetic, that you're born with.
Could be a genetic one. Hypertension is another one, right? Conscious that?
Genetic.
So it's heterogeneous, which means what? There's a whole bunch of things that can cause. Group of diseases. If they all go back to cardiomyopathy, of the myocardium associated with mechanical or electrical dysfunction that usually exhibit inappropriate ventricular hypertrophy, dilation that are due to a variety of causes that are frequently are genetic. Okay. What is ventricular hypertrophy or dilation?
The ventricles are going
Okay, hypertrophy is which one?
fast. Too much.
Inappropriate ventricular hypertrophy or dilation. So hypertrophy is what?
Too fast or too much?
Nope.
Like, growing.
Growing. They get too big.
I said too much. That counts.
Too much. The heart muscle gets too big. Hypertrophy. It gets too big. The volume goes down inside of the ventricle. So it's kind of a double whammy. Now the problem with this, and the difference is, if this happens because of athletics, it's a good thing. If it happens because of hypertension or other pathologies, it's a bad thing. And they're still trying to tease all those different things out. Right? What is dilation?
It gets too big, opens.
It gets too big now at this point, and it loses its contractility with the muscles. And if it can't contract, it gets kind of, just can't contract, you can't get the blood out. The cardiomyopathies either are confined to the heart or are part of the generalized systemic disorder, often leading to cardiovascular death and progressive heart failure related disability. I would throw what into this one.
You would what?
What else would I throw? Say, are either combined to the heart, that's obvious, it's just the heart, right? What's another part of the general systemic disorders? They can tie in with cardiomyopathy. What did we just talk about? What's the big one? Hypertension, the big one, right?
Beat me to it. I was gonna say it.
All right, primary, secondary cardiomyopathies. We'll look at them right now. Primary, good old comment, genetic, hypertrophic, arrhythmogenic, right ventricle, left ventricular, non-compaction cardiomyopathy, inherited conduction system disorders, ion channel pathologies, pathies, mixed cardiomyopathy, dilated cardiomyopathy, restrictive, secondary, and we'll look through some of these in a little bit. Stress cardiomyopathy, alcohol. Did you all know that alcohol can induce cardiomyopathy too? I don't want people to think about stress.